I would like to talk about the anatomy of the spinal cord, the modifications of the pia mater, and we will take a cross section of the spinal cord and see the various tracts, ascending tracts, descending tracts, extra pyramidal tracts, and finally about its blood supply. This is the spinal cord and it is covered by the dura mater. Dura mater is single layered, whereas the cranial dura is double layered. And this is the arachnoid membrane, and here you have the pia mater. So it is covered by dura mater, arachnoid, and pia mater. So in this diagram, this is the spinal cord, and this spinal cord is extending from the C1 to L1, L1 lower border, L1 lower border. So in the adult, the spinal cord is extending from C1 to L1. And at the lower border of L1, you have the conus medullaris, a triangular part, which is a part of the spinal cord. Closely investing the spinal cord, you can see the pia mater, and it is extending from, and this pia mater, it forms a modification at L1 and becomes the phylum terminale. Phylum terminale. So this phylum terminale, it extends from L1 to coccyx region. This phylum terminale is a modification of pia mater. Now this is arachnoid membrane, and this arachnoid membrane, it is ending at the level of S2, lower border, and this outermost is the dura mater, and it converges at S2 and continue towards the coccyx region. So if this is the arachnoid membrane, so this region, this whole region, this is the subarachnoid space, and here actually there is CSF. CSF is floating. As the arachnoid membrane, it is ending at the lower border of S2, we can say that the subarachnoid space also ends at the lower border of S2. So the importance is that in lumbar puncture, the lumbar puncture, it is done at the level of L3, L4 to collect the CSF by inserting a needle at this region, so that we will get the CSF without damaging the spinal cord. So the spinal cord in adult, it ends at the lower border of L1, whereas in newborn it ends at upper border of L3. The arachnoid membrane ends at S2 lower border. So the subarachnoid space also ends at S2 lower border. Now the dura mater ends at, actually it converges at S2 and ends at coccyx, and the pia mater ends at the coccyx region, and we are doing the lumbar puncture at the level of L3, L4 in adult. Another modification of the pia mater is this one, that is a ligamentum denticulatum. it is another modification of the pia mater. Here you can see it is a tooth-like projection, and it is present one on each side. Here there is one, and in this side there is one on each side. There are 21 pairs of denticulate ligaments, and it is a projection. It is a projection where the pia mater connect with the dura mater. So the second modification is a denticulate ligament. The first modification was the phylum terminale. The last projection is located at the level of T12 L1. Last projection. So what is the applied for the ligamentum denticulatum? This region. Actually it is located between the ventral root and the dorsal root. So it is an important landmark for the spinal surgeries. When you are taking a cross section of the spinal cord, this is the H-shaped grammater, and this is the anterior horn, and this is the posterior horn. It is because this is the dorsal root ganglia, which is a sensory ganglia. So this must be dorsal and this must be ventral. So this is a posterior horn and this is the anterior horn. So this is the anterior horn, which is motor, and this is the posterior horn, which is sensory. So in the anterior horn we have the lateral group of nucleus. It is for supplying the limb muscles, that is the upper limb muscles, lower limb muscles, and we have the medial group. It is for supplying the axial muscles, and then we have the central group. The central group, it innervate the phrenic nerve, that is a C3, C4, C5, and for the spinal part of accessory nerve, that is C1 to C5. In the posterior horn, there is substantia gelatinosa. So this will continue above as the spinal nucleus of trigeminal. Above it continues spinal nucleus of trigeminal. And this substantia gelatinosa have the nucleus for the spinothalamic tract. Spinothalamic tract, that is a second order neuron. So this spinothalamic tract, it is actually the second order neuron which is involved in the sensation of the pain, temperature, crude touch. So these sensations are reached to the thalamus, somatosensory region of the thalamus. Then we have the nucleus proprius in front, and in front of the nucleus proprius we have the visceral afferent. Visceral afferent. As the name suggests, it carry the sensation from the viscera. Afferent means sensations, sensory. Then we have the nucleus dorsalis or the Clark's column. Here the nucleus for the spinocerebellar tract is present. Spinocerebellar tract. So the nucleus for the spinocerebellar tract is present in the nucleus dorsalis. So it is taking the proprioceptive information from the spinal cord to the cerebellum. In certain regions, the intermediate nucleus are also present. These two nucleus. We have the intermedio medial nucleus, intermedio lateral nucleus. They are not present throughout. So the intermedio medial nucleus, it is concerned with the parasympathetic, whereas the intermedio lateral nucleus, it is concerned with the sympathetic functions. So the parasympathetic is craniosacral outflow. So they will be present S2 to S4, whereas the intermediate lateral nucleus, they are involved in the sympathetic function. So from T1 to L2, they are present in the T1 to L2 region. If you want to remember it, remember like this: MPLS. So MP, Member of Parliament, Lok Sabha. So the medial nucleus is for parasympathetic, whereas the lateral nucleus is sympathetic function. So these all were the gray matter which I have been discussing. Now we will go on to the white matters. Now talking about the white matters in the spinal cord. So when you guys hear about the tracts, ascending tracts, descending tracts, these are all the white matters. Actually the white matter is the collection of axons and the gray matter is the collection of cell bodies of the neurons. So the collection of the axons in the central nervous system is the tract. We have ascending tract as well as descending tract. So the one marked with red is the descending tract and the one marked with blue is the ascending tract. So we have, this is the anterior white column. This is the lateral white column and this is the posterior white column. So in the descending tract we have the fibers from the cortex to the spinal cord. That is the Corticospinal Tract and fibers from the cortex to the cranial nerve nuclei. That is the Corticonuclear Tract. Corticonuclear Tract. So togetherly they are called as the Pyramidal Tract. And this pyramidal tract, they are very important in the voluntary motor movement. So to control our voluntary movements, this pathway, the pyramidal tract, is very important. So this is the upper motor neuron. So in the pyramidal tract there is upper motor neuron as well as lower motor neuron. The upper motor neuron, it is located in the cortex region, and here you can see the this is a spinal cord region, and the lower motor neuron, it arises from the anterior horn of the spinal cord and it go and innervate the skeletal muscles for voluntary movements. One more very important thing to note is that the lower motor neuron, it can be in the brainstem. There are cranial nerves. For example, this is a third cranial nerve. It is having the motor nucleus. So the cranial nerves which are having the motor nucleus, they are also included in the lower motor neuron. So that means the lower motor neuron, it can pass by the cranial nerve or the spinal nerve. I will give you an example. For example, for the movement of the eyeball, you have the superior rectus, inferior rectus, medial rectus, lateral rectus muscle, and superior oblique, inferior oblique, and other muscle also. So here, if the motor nucleus for the third cranial nerve is arising, so the lower motor neuron will go and innervate the muscles involved in the movement. That is, except the superior oblique and the lateral rectus, which are innervated by fourth and sixth cranial nerve, all other muscles which is controlling the movement of the eyeball is innervated by the third cranial nerve. That is the superior rectus, medial rectus, inferior rectus, inferior oblique muscle, and this will help in controlling the movement of the eyeball. So we can say that the upper motor neuron, this upper motor neuron is controlling the lower motor neuron, and the lower motor neuron is controlling the target. So this is actually what is happening. So there is a tendency that lower motor neuron always try to overact, increase its activity. So the upper motor neuron, it is actually controlling not to overact the lower motor neuron. So if there is a UMN type of lesion, the lower motor neuron is not controlled. That means it will overact. So there will be spastic type of paralysis. The tone will be increased, the reflex will be increased, and the Babinski sign will be positive. Whereas if the lower motor neuron is undergoing lesion, there will be the activity will be reduced. So the flaky type of paralysis will be present. Flaky type of paralysis is present. There is a decrease in the tone, there is a decrease in the reflex, and the Babinski sign will be negative. So now about the lesion, UMN and LMN lesion of the facial nerve. So the space can be divided into a right and a left half. So this is a right nucleus and this is a left nucleus. So the right nucleus and the left nucleus have an upper and a lower part. The upper part will innervate the upper part of the face and the left side, and the lower part of the face will be innervating, the lower part of the nucleus will be innervating the lower part of the face of the corresponding side. So thereby we can divide the face into 4 quadrants. So the cortex always control the opposite side. So the right cortex will be controlling the left nucleus, as well as the left cortex will be controlling the right nucleus. And one more thing to note is that the right cortex will control the upper part of the right nucleus and the left cortex will control the upper part of the left nucleus of the same side. So this is the upper motor neuron and this is the lower motor neuron. If there is a UMN lesion on the left side, that means the right nucleus is affected. That means the right side of the face is affected. But you can see that the upper part of the nucleus on the right side is getting its supply from the same side. That means this will not be affected. So the upper part of the face will not be affected. So only the lower part of the face will be affected. This is happening because you can see that the right cortex, you can see that the right cortex is giving innervation to the upper part of the right nucleus of the same side. That is why this is normal. So always remember this, that in a UMN lesion, the contralateral lower half of the face is affected. You can see that the contralateral only lower part of the face is affected. So if there is an LMN type of lesion, you can see that both the upper and the lower part of the face of the same side is affected. So in LMN lesions, the ipsilateral entire half is affected. Entire half affected. So in the extrapyramidal tract, we have the rubrospinal tract from the red nucleus to the spinal cord, vestibulospinal tract, tectospinal tract, and the reticulospinal tract. So these three, they will descend medially. So they are included in medial motor pathway, whereas the rubrospinal tract, it descends laterally. So it is included in lateral motor pathway. So this rubrospinal tract, it facilitate the flexors. It facilitate the flexors and inhibit the extensor muscles. Vestibulospinal is action is opposite of the reticulospinal tract. That is, it will facilitate the extensors and inhibit the flexors. Now the tectospinal tract. So the tectospinal tract, it actually the reflex movement of the head and neck and the eyeball movements as a response to visual stimuli. So the reflex movements of the head and neck and the eyeball when a visual stimuli comes. For example, if you are walking by a road and something suddenly approaches to you and there is a visual stimuli, you are seeing it. So you will move away from it. So at that time, the reflex response of your head and neck as well as your movement of your eyeball away from it. So so the tectospinal tract is involved in that movements. So the reticulospinal tract, it has two components. That is the Pontine reticulospinal tract, as well as a medullary reticular tract. So it is actually controlling our limb extensors. So this Pontine reticular tract, it is excitatory to the limb extensors, whereas a medullary reticular tract is inhibitory to the limb extensors. So altogether we can say that we have a lateral motor pathway as well as a medial motor pathway. The corticospinal tract as well as a rubrospinal tract is included in the lateral motor pathway. We have the reticulospinal, vestibulospinal as well as the tectospinal in the medial motor pathway. So the lateral motor pathway, it is involved in fine motor movements such as our writing movements. So these writing movements, they involve our distal muscles, and so this is a type of skilled voluntary motor movements. It is a skilled motor movements. So this can be considered as recent in terms of evolution, whereas the medial motor pathway, it is for the posture maintenance and to control the proximal muscle control, or we can say that the paraspinal muscles. So they can be considered as oldest in evolution. So the descending tract, you have close to the anterior median fissure, you have the anterior corticospinal tract, which is this one, and you have the near that you have the tectospinal tract, and you have the vestibulospinal tract. So this is on the lateral side you have the lateral corticospinal tract and the rubrospinal tract. So these are the reticulospinal tract. Now about the ascending or the sensory tract. The very primitive sensation is the pain and temperature. It is carried by the lateral spinothalamic tract, spinal cord to thalamus, the pain and temperature, and the pressure and the crude touch these sensations are carried by the anterior spinothalamic tract. Very advanced sensations such as the fine touch, then the vibrations, then 2-point discrimination, then conscious proprioception, that is the joint position sense, stereognosis. So such advanced sensations are carried by the dorsal white column through the fasciculus gracilis as well as fasciculus cuneatus. So the sensation from the leg, that is the lower limb, is through the fasciculus gracilis, and the sensations of the upper limb, it is through the fasciculus cuneatus. So what is meant by this stereognosis? You close your eyes, and if some object is given in your hand, and if you can identify by closing your eyes that it's a pen, that is termed as the stereognosis. So if there is a lesion in the dorsal column tract, you cannot identify it by merely touching the familiar objects. Proprioception means joint position sense. That means if you close your eyes and you can move your hands and fingers, and without opening your eyes you can sense that where your hand is present, and with the opposite hand you can even touch the target, because in your brain it is calculated that how much angle it has moved and in which direction it is present. So without looking itself you can understand where it is actually present. That is a proprioception. The unconscious proprioception, it is carried by the spinocerebellar tract. So this is a spinocerebellar tract. The unconscious proprioception is carried through the spinocerebellar tract. So now talking about the spinothalamic tract. So this is the dorsal root ganglion, the first order neuron. This is a pseudo unipolar neuron. It takes the sensation and it go and relay in the substantia gelatinosa. So this is the first order neuron. And the second order neuron, so this is the second order neuron. It crosses the opposite side. Here you can see that the first order neuron is coming from the mechanoreceptors, and this is the second order neuron, the chief sensory neuron. It crosses to the opposite sides and it ascends as the anterior spinothalamic tract. It goes through the medulla and the pons and it reaches the thalamus, where it relay with the third order neuron, that is a VPL nucleus of thalamus. So the third order neuron originates from here and will be projecting into the postcentral gyrus area 312 to the sensory cortex by the thalamocortical radiations. So the sensation carried is crude touch and pressure. The pain and temperature is through the lateral spinothalamic tract. So the result, for example, this is the temperature pathway. So we have two type of receptors. One is for detection of cold, we have A delta fibers and unmyelinated C fiber. For detection of warm, we have unmyelinated C fiber. So this is the dorsal root ganglia, and the first order neuron is relaying at here. Lamina 1, 2, 3. Lamina 1, 2, 3, and the second order neuron originate and it crosses to the opposite side and it ascends and it reaches the thalamus, VPL nucleus of the thalamus. And the third order neuron originates from here, and as thalamic radiation, it projects to the sensory cortex, post-central gyrus area, broad main area 312. So here you can see that while the lateral spinothalamic tract is ascending at the level of brainstem, it gives collateral fibers to the reticular area in the brainstem. The the pain sensation is also taken through the lateral spinothalamic tract. So we have nociceptors free nerve ending. The receptor for pain is a nociceptor and we have the free nerve ending. So A delta fibers and C fibers. A delta fibers for fast pain and the C fiber for slow pain. So these sensations are taken to the substantia gelatinosa, and here you can see the second order neuron originates here. It crosses to the opposite side and it ascends. So through the brainstem it reaches the thalamus, VPL, ventro-posterolateral nucleus of the thalamus. The third order neuron originates from here and it projects to the sensory cortex, that is the post-central gyrus broad-main area 312. So here we are having two tracts. Paleo means old, spinothalamic. So paleospinothalamic tract is for slow pain, whereas the neospinothalamic tract, it is for fast pain. So what is this fast pain and the slow pain? So when you are pin pricking on your finger, the first pain that you feel is the fast pain, whereas after some time you will feel a diffuser type of pain. That pain is called the slow pain. So during its ascent, it gives fibers to the reticular nucleus, tactile area, periaqueductal gray matter as collateral fibers. Details of the reticular formation and the pain will be taken in another video. So what is the applied of this? So if there is a lesion on the spinothalamic tract, if there is a lesion at the level of the spinal cord or the brain stem, so if there is a lesion, there will be contralateral loss. Contralateral loss of pain, temperature, crude touch and pressure, because these sensations are all carried by the spinothalamic tract, and you can see that spinothalamic tract, it is crossing at the spinal cord level. So that means if there is a lesion in this region, that is either at the level of brainstem or the spinal cord, there will be contralateral loss of the sensations which are carried through the spinothalamic tract. So next is about the dorsal column pathway, which is carrying the advanced senses such as the fine touch, proprioception. So here you can see this is a first order neuron. This first order neuron, so without relaying in the spinal cord, it ascends and it relay in the medulla. You can see this is the nucleus gracilis and this is the nucleus cuneatus. Nucleus cuneatus. And the other one is the nucleus gracilis. In the medulla, you can see that they will cross to the opposite sides. and these fibers are called the internal arcuate fibers. Internal arcuate fibers, and they will ascend together as the medial lemniscus. So medial lemniscus, and they will relay at the thalamus, VPL, ventroposterolateral nucleus of thalamus, and the third order neuron originate from here, and as thalamic radiation they will go to the postcentral gyrus, sensory cortex, broad main area 3, 1, 2. That is why this pathway can be called as dorsal column medial lemniscus pathway. Here you can note that the fibers coming from the lower part, that is lumbar and sacral segments, are more medial, and this is called a tract of gold. Tract of gold, and the fibers which are coming from upper side, that is the cervical and thoracic region, this is the tract of Burdach. It can be called as tract of Burdach. Actually, the lower limb sensations are coming from the tract of gold, and they will be reaching at the nucleus gracilis, whereas the nucleus cuneatus will be having the upper limb sensations. So here the applied is, if there is a lesion in the spinal cord, then you can see that the same side of the body will be affected, and if there is a lesion in the brain stem, you can see that opposite side of the body will be affected. So now the spinocerebellar tract, we have anterior as well as posterior spinocerebellar tract. So you can see this is a first order neuron which is taking the sensation, and it go and relay the clerk column. This is the clerk column. Clerk's column, and the second order neuron. So this anterior, this posterior, this one is a posterior spinocerebellar tract. It ascends posterolaterally and it enters the cerebellum through the inferior cerebellar peduncle. Through the inferior cerebellar peduncle. So the peduncle is, it is a bundle of white matter. Actually, we are having three cerebellar peduncles: superior, middle, inferior. Superior cerebellar peduncle means the cerebellum connecting with the midbrain. Middle, it will be connecting to the pons, and inferior connecting with the medulla. And one more point to be noted is that this posterior spinocerebellar tract is entering the cerebellum to the same side, ipsilateral, to the same side of cerebellum. Now talking about the anterior spinocerebellar tract, the first order neuron relay in the Clerk's column, second order neuron originate from the Clerk's column. It is crossing the opposite side and reaches anterolaterally, and then it ascends as the anterior spinocerebellar tract, and it enters the cerebellum ipsilateral side through the superior cerebellar peduncle. Through the superior cerebellar peduncle. So we can say that all the ascending tract decussate except the posterior spinocerebellar tract. Spinocerebellar tract. So now talking about the descending pathway. So this is a pyramidal tract. This is a motor cortex. So from the motor cortex through the corona radiata, fibers reach the internal capsule, the genu, as well as anterior 2/3 of the posterior limb of the internal capsule. Then they will descend to reach the midbrain at the crus cerebri. Then they will reach the pons, And after reaching the medulla, 80% of the fibers, they will cross to the opposite side. That is called the pyramidal decussation. Pyramidal decussation. And they will become the lateral corticospinal tract. So this is a lateral corticospinal tract. 20% of the fibers, they will continue as the ventral corticospinal tract. So the 20% of the ventral corticospinal tract, they cross from the spinal cord to the opposite side. So altogether there is 100% crossing. After crossing, they will end in the anterior horn of the spinal cord. So the applied here is, if there is a lesion in the corticospinal tract at the level of brainstem, that means anywhere here. Actually, the fibers are actually crossing at the lower part of the medulla as a pyramidal decussation. So the opposite half of the body will be affected. So there will be contralateral, that means opposite side, hemiplegia. Hemiplegia. So the next case is, if there is a lesion in the spinal cord, then there will be, you can see, there will be same side ipsilateral hemiplegia will be there. Hemiplegia. Because fibers are already crossed, so they will be, the same side of the body will be affected. So from the cortex, the descending, there is a descending pathway. 30% of the fibers, they are coming from the primary motor cortex. There are 30%, another 30% of fibers are coming from the premotor cortex and supplementary motor cortex. And 40% of the fibers are coming from the somatosensory area. In the pyramidal tract, actually we have corticospinal tract as well as corticonuclear tract. So the corticonuclear tract, it passes through the genu of the internal capsule, whereas the corticospinal tract passes through the posterior limb of the internal capsule. So in the posterior limb, the anterior two-third portion. So in your brain, the internal capsule is something like this. It is having an anterior limb. This is the genu, and it is also having the posterior limb. So this is the anterior two-third of the posterior limb. So this is where through which the white fibers are passing. So the corticonuclear tract, you can see origin, it is same as that of the corticospinal tract. It passes through the genu of the internal capsule. Then it passes through the crus cerebrae of the midbrain. So in brainstem, this midbrain, pons, medulla, togetherly they are called the brainstem. So in brainstem, they will cross to the opposite side and will supply the cranial nerve nuclei. Either they will give directly or they will through the interneuron. So this one is an interneuron. So either directly or through the interneuron. So here you can see that the third, fourth cranial nerve, they are supplying the muscles of the eyeball. So they are having the motor fibers. So the motor nucleus are located at the midbrain. And in pons 5, 6, 7, cranial nerve 5, 6, 7, their motor nucleus are located within pons. 6 is concerned with the movement of eyeball, 5 is a trigeminal, and 7 is a facial nerve. So it is also having motor innervation. Whereas 9, 10, 11, 12, so their motor nucleus is located in the medulla region. Cranial nerve 8 is vestibulocochlear, it is purely sensory. Whereas 9, 10, 11, 12 is having its motor part. So its motor nuclei is located in the medulla. So one applied I have to discuss here is Tabish dorsalis. It is found in syphilis. In syphilis, here the dorsal column tract is affected. So there is loss of position and the vibration sense. So this loss of position sense, but this position sense, it can be maintained by the visual stimuli. So when the patient is asked to close his eyes, he tends to fall. So this sign is called as Romberg sign. So this Romberg sign is seen in Tabish Dorsalis. So the next applied is the Brown sequard syndrome. So here there is hemisection of the spinal cord. Here you can see that the T12 segment is affected. So say this is his right side and this is his left side. This is his right and this is the left side. So first one, what happens to the spinothalamic tract? So when there is a lesion on the spinothalamic tract, either in the brainstem or at the level of spinal cord, there will be contralateral loss of pain, temperature, crude touch, pressure, sensation below the level of lesion. That is, the lesion is on the right side, so below the level of lesion, that is here. It will be affected. It is because they are crossing at the spinal level. So here we can see that the dorsal column is affected. So if the dorsal column is affected, you can see that there will be loss of proprioception, vibration, 2-point discrimination below the level of lesion on the same side. It is because they are crossing at the level of medulla, lower part of the medulla, pyramidal decussation. So if there is a lesion on the brainstem, it will be on the opposite side. If the lesion is on the spinal cord, it is on the same side. Then the corticospinal tract will be affected. So as this is at the level of the spinal cord, there will be lesion on the same side. On the same side below the level of the lesion. So you can say that at the level of lesion, there is loss of all sensations. All sensations are lost at the level of lesion because no fibers can enter. Now coming on to the blood supply of the spinal cord, we have two type of arteries. One is the long arteries and the another one is a segmental arteries. So we have one anterior spinal artery, that is this one, which is arising from the vertebral artery. So this is a vertebral artery which will continue as a basilar artery. So this is basilar artery and this is vertebral artery. From the vertebral artery, the anterior spinal artery will arise and we have one anterior spinal artery. But we are having two posterior spinal artery. So this is a posterior spinal artery. We are having two posterior spinal artery and it is arising either from the pica, posterior inferior cerebellar artery, or it can also arise from the vertebral artery. So in this diagram it is arising from the, you can see this is a vertebral artery, it is arising from the vertebral artery, but it can also arise from the posterior inferior cerebellar artery. So these are the long arteries, anterior spinal artery as well as posterior spinal artery. Now we have the segmental arteries. So now which are the segmental arteries? So this is a vertebral artery, so it can give segmental arteries. Then this artery, that is a deep cervical artery, it is also a segmental artery. Now the intercostal arteries, here you can see the intercostal arteries, they can also give the segmental arteries. They can also provide segmental arteries. Then the lumbar arteries, they also can provide the segmental arteries. Now what are these pile plexus? Here you can see that the segmental arteries, They are anastomosing with the long arteries. The segmental artery anastomosing with the long arteries. So this is the pile plexus. This anastomosis is the pile plexus. Here you can see that the segmental arteries, they will give the ventral as well as the dorsal radicular artery. Ventral radicular artery as well as dorsal radicular artery through the ventral rami as well as through the dorsal rami. Sorry, it is not ventral rami, it is through ventral root and through the dorsal root. You can see that this ventral radicular artery, it comes and reaches, this is an anterior median fissure. Anterior median fissure. So it comes and reaches at the anterior median fissure and divides into a descending as well as ascending branch. And here they anastomose with the long arteries. So these branches can be called as anterior radiculomedullary artery. Anterior radiculomedullary artery. Another one of the most important point is the artery of Adam-Kiewicz. Artery of Adam-Kiewicz. It is the largest It is the largest radiculomedullary artery. Anterior radiculomedullary artery. It is a major supply to the lower 2/3 of the spinal cord, and mostly it is originating from the left side, as you can see right here, left side, and it will be originating from the lower intercostal artery or the subcostal artery or the lumbar artery. So it is also called as the largest feeder artery. Now one more thing, the anterior 2/3 of the spinal cord, it is supplied by anterior spinal artery, and the posterior 1/3 of the spinal cord is supplied by the posterior spinal artery. So that's all about the spinal cord.